Insulin got Nobel Prize in which year? Same options are the same. Nobel Prize for insulin was given in which year? It was discovered in 21. Okay. My question is Nobel Prize. 23 is the right answer.
We get 10 marks.
Okay. It was given to, Nobel Prize was given to, who is MacLeod? He is a professor of physiology. Banting, what is the specialty of the Banting? He is an orthopedic surgeon. Orthopedic surgeon worked in the Department of Physiology and Dictation. And Banting requested the HOD, MacLeod, to sponsor him or to give him some unusual lab for the purpose of the pancreatic experiments. So MacLeod has given an unused lab and repeated requests from the MacLeod and also requests from the HOD of the medicine and the Sopertech. So no medical student was interested to work with the Banting because he was an orthopedic surgeon deputed in the physiology department. He is not having the good relations with the professor of the physiology, MacLeod. So anyhow, he has to given one student for his assistance. So by point test, he got best to get work with the Banting. And finally, the result, you know that one of the important molecules in the world, the superb molecule in the world is the insulin. So they invented Banting and the best. But Nobel Prize should not be given to a medical student. So it should be given to the professor and the chief investigator like that. So Banting got, without doing any work, MacLeod also got the Nobel Prize because he was the professor of the physiology. Now the Banting shared his prize with the best, whereas the MacLeod shared his prize with the Colip, who was the physics HOD. So he made impure insulin to become the more purified so that the allergic reactions will not be there. So that is the story of the insulin. Now the second, the term diabetes was introduced by. Yes, you are right. Correct.
In 5 marks.
So he described two types of the pancreatic actions. One is exocrine, another one is endocrine. He could not recognize that endocrine function, and finally later after his death, someone identified the endocrine function of those islets which were first described by the Langerhans. So that is the reason islets of the Langerhans. The commonest complication of diabetes among the following: retinopathy, neuropathy, coronary artery disease, and PVD, peripheral vascular disease. Wrong answer.
TB.
Coronary artery disease is wrong.
PE.
Neuropathy is the right answer.
PE 5 marks.
See, as Madam Yashodham is saying that, so 40 to 50% of the people, they present with the complications. So even today, we get lot of the reference from the ophthalmology friends. So the diabetic, he developed a dimness of the vision or the loss of the vision. He approached an ophthalmologist and he said that it is a proliferative diabetic retinopathy or vitreal hemorrhage or retinal detachment. These are all complications of the diabetes. Then he asked the leading question to that particular person, what is the duration of the diabetes? Then you check the blood sugar, the sister checks it, and it is about 450 or 550 or 600. Then he referred to a physician or a diabetologist or endocrinologist for the proper control of the diabetes. So the neuropathy is the most common symptom, unrecognized. Even today, it is a very, very troublesome, and some people will have the secret symptoms also about the neuropathy, and it is about sensory neuropathy, motor neuropathy, autonomic neuropathy. And the people with autonomic neuropathy, diabetes, they die suddenly with a sudden cardiac arrest. Okay, so autonomic neuropathy is a very big problem in this. And autonomic neuropathy are different organs. If it is cardiac autonomopathy, you can consider as the CAN, cardiac autonomic neuropathy, in the gastrointestinal autonomic neuropathy, or a genitourinary autonomic neuropathy, and etc. And coronary artery disease, very, very common. The most common cause of death in India in diabetes is myocardial infarction. So the coronary artery disease is very, very common in the diabetic individual. That is the reason the cardiacs say that the diabetes is our disease. So the diabetes is considered as the myocardial infarction equivalent. So if you see two people, one fellow is discharged from the Apollo hospital with the diagnosis of acute myocardial infarction and PTCA to the left main coronary artery. And another fellow discharged from a hospital saying that type 2 diabetes uncontrolled, the HbA1c 14 or 15. And if you follow these two people, and the fellow with the diabetes, they die much early when compared to the fellow who got PTCA, etc. So that clearly shows that the presence of the diabetes itself is a big risk factor to cause early death, early morbidity and the mortality. So that is the reason. Don't think that diabetes is a very simple disease. It is a very, very big disease, and we have to treat the diabetes very effectively and very aggressively. And of course, peripheral vascular disease, PVD, it is a very common. The common symptom here is the intermittent claudication. Very common in the smokers. So the diabetes plus smoking is a very, very big risk factor for the all vessels, including the micro vessels and also the macro vessels. So these people will present with toe amputation and then foot amputation, below knee amputation, above knee amputation, total amputation, etc., etc. And finally, these people will also die much early when compared to the other people who are not having peripheral vascular disease. Here, ABI is very important, ankle brachial index. It should be more than 0.9. If it is less than 0.9, it is a suggestive of the peripheral vascular disease. Between 7.5 and 0.9, it is a mild. Between 0.4 and the 0.75, it is a moderate. Less than the 0.4 is severe. So once the ABI is less than the 0.4, it is better to shift to the surgeon for the amputation, early amputation. So that is the importance of the peripheral. Which of the following statements is false regarding neoglucogenesis? B. Right answer. Right answer. See, the neoglucogenesis is a very, very important thing. Very, very important because see, all the diabetics, you all know that glucose diabetes means glucose or the sugar. This glucose will be converted to the glycogen for the storage form. So this glycogen will be there in the liver, in the muscle, and also in the adipose tissue. So when the fellow is on the fasting, this stored glucose, that is the glycogen, will be converted to the glucose, that is called glycogenolysis. And sometimes when the fellow is on the prolonged fasting, then the fat cells also will get converted to the free fatty acids, and then through the lactate and the pyruvate, again they produce the glucose. This process is called neoglucogenesis. So getting the glucose not from the glycogen or not from the glucose, from through amino acids and the fatty acids. So that is the main glucogenic substance are amino acids and the lactate. Yes, B is wrong. And neoglucogen helps maintain the blood glucose levels after 12 hours of the fasting. That is the reason some fellows on the fasting for 5 days, 6 days, 7 days, etc. And we check the ketone bodies. So once the ketone bodies is positive, so that is very dangerous. Okay? And the last one is the major site of the neoglucogenesis is the liver and muscle.
Which of the following is an indicator of insulin resistance?
So all of them is the right answer. So you got very simple question. No? Okay. So see, acanthus nigricans, these are very, very important. See, nowadays we are seeing young diabetics. Say recently I have seen one girl aged about 11 years studying 6th class with diabetes. They approached the pediatrician and they started insulin therapy. So in respect to the age, but on insulin therapy, she is getting prolonged hypoglycemias and frequent hypoglycemias. So they approached me. When I examined her, she had a beautiful acanthus nigricans on the nape of the neck, on the folds, on the axillary folds, on the cubital folds. So acanthus nigricans means insulin resistance. So insulin resistance means type 2 diabetes. Type 1 diabetes means insulin deficiency, absolute loss of the beta cell function. So you don't have acanthus nigricans, you don't have the skin tags, you don't have the central obesity in type 1 diabetes. So that is almost like a pure endocrine disease. Whereas in type 2 diabetes, it is because of insulin resistance. So that is the reason in India, insulin resistance is much more than the insulin deficiency in Indian population. So this insulin resistance is again, these are all the markers of the insulin resistance, especially the central obesity is a big marker of the insulin resistance. So I stopped insulin, started on the metformin. Now she is doing good without any hypoglycemia. See, at the age of 12 years, type 2 diabetes. So early onset of the type 2 diabetes is also common in Indian population. Is
Which
wrong
of the
answer.
following is not a component of the metabolic
Right?
syndrome?
That is the right answer. Right answer. See, if you see the metabolic syndrome,
TB 5 months.
as I told you, the metabolic syndrome, the four things. One is diabetes, hypertension, obesity, dyslipidemia. So in the dyslipidemia, they didn't comment on the LDL cholesterol, which is very, very important for our clinical practice. So they commented on the HDL, they commented on the triglycerides, and then they commented on the LDL, not the high. It is not the high LDL, it is a small and the dense LDL, which is responsible for your atherosclerosis. So need not be always having the high LDL cholesterol. Even though the LDL appears to be the normal, say 70 or the 80 or the 90, but if you see the particle, that is very small and the dense. So small and the dense LDL particles are more atherosclerotic. Low HDL, unfortunately, Indians, I told you earlier in my inaugural remarks, our people, Indian people, is different from the Western population as far as the diabetes is concerned by 10 to 15 points. And one point again here is the HDL cholesterol. If you check the HDL cholesterol in Indian population, 80 to 90% of the people are having the low HDL. Okay, males it should be more than 40, in females it should be more than 50. But most of our people will have the HDL 28, 30, 34, 35, etc. That itself is a big risk factor for the atherosclerosis and ischemic heart disease.
Which is the ongoing program conducted by the Government of India
SPM.
concerning diabetes?
SPM, Delhi or Bombay. Okay, right. You are right. It is not diabetes prevention or national diabetes control program. It is the national program for prevention and control of non-communicable diseases. Not only the diabetes, but also the strokes, okay, and also the hypertension, etc. And also the oncology, malignancies also. Malignancies. So they have said a non-communicable disease. Here the diabetes, hypertension, strokes, and also oncology.
Regarding HbA1c testing, all the following are the true except.
Measured in the fasting, you mean at any time? You are right. So need not be on the fasting because you are checking the HbA1c, which is an average of the previous 3 to 4 months. So it may be the random or the postprandial or the fasting, nothing to do with the fasting state. Excellent. It is an indicator for the average blood glucose. C may be inaccurate in the presence of hemoglobin variants. You see the hemoglobinopathies, or Rampar, Koya, etc., etc. So those people will be having a variant HbA1c. The same with the severe anemia also. If you see the GDM population, if the fellow is having hemoglobin is 7 or 8, and if you check the HbA1c, it is not accurate because HbA1c depends on the RBC function. It can also be used for the diagnosis of the diabetes. Earlier, the diagnosis of the diabetes means only 3. One is the fasting, postprandial, random. Fasting more than 126, postprandial more than 200, random more than 200 plus symptomatic. So these 3 are the criteria for the diabetes. And late in 1799, I think, HbA1c also included as a diagnostic criteria in diabetes. Now you have the 4 criteria. So fasting more than 126, postprandial more than 200, random more than 200 plus symptoms, and HbA1c more than 6.5. What is the normal HbA1c? 5.6. What is the pre-diabetic HbA1c? 5.7 to 6.5. What is the normal fasting blood sugar? Less than 100. IFG, impaired fasting glucose, 101 to 135. What is the normal postprandial? Less than 140. What is IGT? Impaired glucose tolerance, 141 to 199. So these figures should be very pakka. So the normal fasting less than 100, 101 to 125, impaired fasting glucose are the pre-diabetic. 126 or more than 126 is a diabetic. Okay, up to 140 postprandial is the normal. 141 to 199 is impaired glucose tolerance or pre-diabetes, and more than 200 is diabetes.
A 20-year-old male comes to you for assessment of diabetic status. He is non-obese with a body mass index 20.6 kg per mass and has been treated with oral diabetes medications for the past 4 years. His diabetes is under good control with fasting and postprandial blood glucose values of 109 and 146 mg per day, respectively. He reveals that his father and paternal grandmother both have diabetes and that his father developed diabetes at the age of 25 years. What is the most likely diagnosis?
Right answer. See, whenever you see a diabetic in the young individuals, 4 causes are there. Diabetes in young, 4 reasons. Number 1, early onset of the type 2 diabetes. That's what I discussed earlier. Number 2, it could be type 1 diabetes because type 1 diabetes can occur at any age group. 90% it occurs below the less than the 20 years of age group. I have seen few cases at the age of 67, 78, 80 years, they present with the type 1 diabetes. So the type 1 diabetes can occur at any age group. So that could be the one possibility here. Early onset of the type 2 diabetes is another possibility. And then monogenic diabetes, that is a MODI, maturity onset diabetes in the young individuals. So you have the 8 or the 9 MODIs. If you see the book, there are the 6 MODIs. Now the 7, 8, 9 is also added. That is the monogenic diabetes. So you have to do the genetic testing. So the features of the monogenic diabetes here is the 2 points. One is it runs in 3 generations. It runs in 3 generations. So this fellow is a diabetic and the father is a diabetic and the paternal grandmother is also diabetic. So runs in the 3 generations and at the age of 20 years young. So it most probably monogenic diabetes. See the sugars here, fasting and the postprandial 109 and 146. Very minimal hyperglycemia. If you take the type 1 diabetes, the fasting will be 250, postprandial will be 350 or the 400. And slowly progressive type 2, early onset of the type 2 diabetes, they are not overweight or obese. Here the BMI, what is the BMI, normal BMI? In Indian population, is it 25 or 23? 23, up to 23 is the normal. So don't consider 25. If you see the Hassan or the Davidson, 25 to 30 is the overweight, more than the 30 is the obese. For Indians, 23, up to 23 is the normal. So 23 to 25, some people say 23 to 27 are the overweight, and beyond 27, you are obese. Yeah. So here 20.6. So it's not overweight, it's a normal weight. So these 2 points clinches towards your monogenic diabetes.
A lean 18 years old female not known to have diabetes comes to you with complaints of polyuria, polydipsia and polyphagia. She gives history of recurrent attacks of abdominal pain and greasy stools since childhood. Her fasting blood glucose value is 366 mg per dl and postprandial blood glucose value is 436 mg per dl. Urine ketones are negative. What investigation will clinch the diagnosis?
Right. So what is the possibility here? See, I told you 3 possibilities earlier. Young diabetics. One is type 1 diabetes, early onset of the type 2 diabetes, MODI, and the 4th one is this one, FCPD, fibrocalculous pancreatic diabetes. Here, if you see here, the fasting is very high, postprandial is very high, but if you see the urine creatine bodies, they are the negative. So ketosis resistant hyperglycemia is a feature of fibrocalculous pancreatic diabetes. So they present with pancreatitis pictures. So if you take an X-ray, so you will have a beautiful pancreatic calculi. So that clinches your diagnosis as the FCPD. So very common in Kerala, also in some states of the Tamil Nadu, and also we also see in Andhra Pradesh, in our area, we see a lot of the FCPDs. So GAD antibodies positive, GAD65 positive, that means autoimmune diabetes. Autoimmune diabetes could be type 1 diabetes or could be LADA also. So latent autoimmune diabetes in the young individual, adults, they are also GAD65 and be positive. Genetic screening for your MODIs to rule out your MODI. And C-peptide is an indicator of insulin secretion. So the more the C-peptide, the more the beta cell function. The lower the C-peptide, lower the beta cell function. So tell me what will happen in the type 2 diabetes in C-peptide. Is it low, normal or high? Type 2 diabetes. High. So there will be hyperinsulinemia in type 2 diabetes. What will happen in type 1 diabetes? C peptide. Low or 0. Okay. So that is how the answer. Here the plain example is the right answer to rule out the pancreatitis.
Which of the following patients is a candidate for diabetes screening?
All of them is the right answer.
And
See, obese 26-year-old male with the family history of the diabetes. Definitely we have to do it because all obese with a strong family history. 35-year-old lady with the past history of the gestational diabetes. So today's gestational diabetes means tomorrow's type 2 diabetes. So in India, it is much early also. Maybe after 3 years or the 4 years of the GDM. So most of the people will turn up into the type 2 diabetes. Not only the mother, the offspring born to the diabetic mother is also at risk of getting the type 2 diabetes. So while treating the diabetes in the pregnancy, you are dealing with the 2 generations. Not only the mother and also the so that is the motion is they have to get the GTT 6 weeks after the delivery. First one, next 6 months after the delivery, and then yearly once thereafter to detect the diabetes, type 2 diabetes at an early age. A lean 28-year-old male with HDL cholesterol 23. So again, I told you, HDL cholesterol is at a lower level to get the insulin resistance. So the metabolic syndrome. So the root cause of the metabolic syndrome is again insulin resistance. So insulin resistance is the cause for diabetes, hypertension, dyslipidemia, and obesity. So the right answer is all of them.
Regarding alcohol and diabetes, all the following are true except
See, it contributes empty calories, right? Potentiates hypoglycemia. That's a very common approach to alcoholism. So increase the neoglucogens. You won't get hypoglycemia if there is neoglucogenesis. If you want the glucose, when the glucose is released in your body, you won't get any hypoglycemia. So if you say yes to the B, C should be the wrong. Okay. And they is safe at an intake of below 60 ml. So all the non-alcoholics, don't advise them to go to the alcoholism. When the fellow is a chronic alcoholic, advise him to limit to the 60 or the 90 ml per day. So that is our.
which of the following trials is concerned with type 1 diabetes?
Right answer. These are the very, very big trials in type 2 in diabetes. See, UKPDS in type 2 diabetes. Okay, from 77 to 99. So the lot of the people are on the post UKPDS trial right now. DCCT, the trial was on type 1 diabetes. UKPDS and type 2 diabetes. That is the reason we get a lot of the knowledge from the UKPDS because our people are 90% are the type 2 diabetes. So we give a lot of importance to the UKPDS because the trial was conducted in the type 2 diabetes. DCCT and the type 1 diabetes. ACCORD trial prematurely terminated for the fear of hypoglycemia. So in ACCORD trial, they did the 2 things. One is they have taken the 100 diabetics. In 50 diabetics, intensive management. In another 50 patients, they lose management. These ICUs, these people used to die much early. So because of the intensification of your insulin therapy in the ICUs. So that is the reason we keep the blood sugars in the ICU. What is your target of the blood sugar in the ICU? What is your target blood sugars in the ICUs? A, 100 to 110. B, 110 to 140. C, 140 to 180. D, 150 to 200. Yes, 140 to. So that 140 is because of the ACCORD trial. So earlier the target is 110. So if you keep the blood at 100, less than the 110, so those lot of the people they used to die because of the arrhythmias. So then they made the ICU targets of your blood sugars as 140, between 140 and 180. So once the blood sugars are more than 180, increase the insulin concentration. If it is 140 to 180, suppose the patient is on 3 ml per hour, continue the same. If it is less than the 140, make from 3 ml to the 2 ml or 1.5 ml or 1 ml. Okay. And if they reach the 100, stop taking the insulin because they are at the very high intake of high risk of hypoglycemia.
Which of the following agents is not of use in controlling fasting hyperglycemia?
Right answer. See, controlling the fasting hyperglycemia. So, glimepiride is an excellent drug, sulfonylureas. Metformin, yes, it also can because it reduces your hepatic glucose output. Metformin mostly acts on the muscle, liver, and adipose tissue. It attacks the insulin resistance. Voglibose, postprandial hyperglycemia. So, it prevents the absorption of your blood sugars, so carbohydrates from the intestines. So that is the voglibose. So when the fellow is at the fasting hyperglycemia, so voglibose will control only postprandial hyperglycemia. Pioglitazone controls the. So tell me what is the amount of the HbA1c reduction with these drugs? What is the amount of your HbA1c reduction with these drugs? Say glimepiride, how much HbA1c reduction will be there? 1 to right answer. Metformin 1.5 to 2, 1.5 say not 1, 1.5 to 2%, glimepiride 1.5 to 2%, metformin. Voglibose 0.4, 0.4%. Pioglitazone 0.8. Now tell me which medication will control blood sugars much better when compared to the glimepiride and the metformin? More than the glimepiride and the metformin. GLP-1 will reduce by 1.2 to 1.6. Yes, right answer. Medical nutrition therapy, not pharmacological management. Your diet, exercise, yoga, and meditation, they reduce the blood sugars, HbA1c to the tune of about 2 to 2.5%. Beyond that, thanks to medical student, insulin, infinite. So that is the reason when the HbA1c is 18, 17, 15, we use only insulin. And within 3 months or the 6 months, if they maintain basal bolus therapy, and obviously can achieve the HbA1c in the next 3 months, maybe 8 or 9 or 10 is also possible. So the infinite reduction will be seen with the insulin. So the weakest molecule is voglibose. That is an alpha glucosidase inhibitors, 0.4%. Okay.
Which of the following is not a contraindication to metformin therapy?
Excellent. Right. See, the metformin, you should know everything about the metformin. See, as I told you clearly that the most common cause of diabetes in India is the insulin resistance. The best drug to tackle the insulin resistance is the metformin. So that is the reason the drug after your medical nutrition therapy, the first drug to be started in all the diabetics in India, unless otherwise contraindicated, is metformin. Now tell me the contraindications. So number one contraindication is gastrointestinal side effects. So nausea, vomiting, etc. That is the reason don't start the metformin with 500 mg BD or 500 mg PAD or 1 gram BD or 1 gram TID. Always start with the low dose. Low dose means 250 milligrams. OD for 3 days or the 4 days. If the patient doesn't develop any gastrointestinal side effects, then make it 250 mg PD. Then the 500 mg OD or the 500 mg PD like that. Because almost metformin can be considered as a drug of your Joyalukkas or Kalyani Jewelries, etc. for the woman. See, the most useful drug, most favorite drug, most say I give metformin 100 marks to the metformin. So I always say that metformin is the drug of choice from A to A. A means Aduku Tinevadu, another A is Ambani in type 2 diabetes. So you can't treat type 2 diabetes without any metformin advantages. So in that way, when you start the metformin all the type 2 diabetics, see you are treating an asymptomatic fellow. Nothing will happen if you take 10 days or the 15 days for the proper control of the diabetes. So already the HbA1c here is a 9 or the 10 or the 11. That means he must be a diabetic for the last 2 years or 3 years or 4 years, undiagnosed and undertreated. So that is the beauty of the metformin. One, the renal failure. So don't give the metformin in the renal failure population because for the fear of metabolic acidosis, not only the metabolic acidosis, lactic acidosis. So the lactic acidosis is much more dangerous than the metabolic acidosis. Okay. And then the cardiac failure. So again, in hypoxic conditions, don't give the metformin. And the severe respiratory failure, again here the hypoxia. But in the fatty liver, what you mean by the fatty liver? The commonest ultrasound diagnosis nowadays, ultrasound abdomen, fatty liver, 1, 2, 3, etc. etc. So that fatty liver is nothing but your bilirubin will be the normal, your alkaline phosphatase will be the normal, your serum proteins will be the normal, your PT-INR will be the normal, but SGPT, SGOT will be abnormal. Okay, so that is your fatty liver. So the fatty liver shows that more of insulin resistance. So again, no, the fatty liver is also the fifth part of your metabolic syndrome. So I told you the 4 parts of the metabolic syndrome. The fifth part, you include the fatty liver also as an extension of your MS, metabolic syndrome. So again, the metformin is a beautiful drug to be used here. So fortunately, we have been using the metformin since its availability to the world. So the metformin was available in 50s. Sulfonylurea is also in the 50s. So from the 22 to 21 to 51 or 52, for about the 30 years, the only drug available for the diabetes is the insulin, whether it's the type 1 diabetes or the type 2 diabetes. The sulfonylureas and the metformin entered into the market in the 55s. And India, we have been using the metformin since 55. But whereas in America, US, the metformin was introduced in America in 99 or maybe the 2000s. So they didn't use the metformin for the fear of the metabolic acidosis or the lactic acidosis. So that is the beauty of the metformin.
Which of the following anti-diabetic agent is considered relatively safe in renal insufficiency?
Dipigel, D is the right. That is the right answer because it is a shortest acting sulfonylurea. So if you take the glycoside, it is a very good for the cardiology patients. Your myocardial reconditioning, etc. That is good with the glycoside. So that is the reason with the IHD or with the heart failure, if you want to use the sulfonylurea, usually we don't use the sulfonylurea in such situations, but still you want to use the sulfonylurea, glycoside is the best molecule. Glibenclamide, we don't use the glibenclamide because of prolonged hypoglycemia. But we use the glibenclamide in Africa people, they use the glibenclamide in gestational diabetes. Because the only sulfonylurea which does not cross the placental barrier is the glibenclamide. So they use metformin and the glibenclamide. Okay. Then the glimepiride, your favorite molecule right now. So they were all Indians' favorite sulfonylurea right now is the glimepiride, which acts about 24 hours. Okay. Glipizide is the shortest acting, maybe 4 hours, 5 hours, 6 hours, 7 hours. Even though they get the hypoglycemia, that can be easily corrected. So that is the drug of the choice for in Uddanam area. Uddanam area in Srikakulam district, famous for your renal failures. So if the person is also happens to be a diabetic, and if you want to use if the people doesn't like the insulin because of the rural background, so if you want to control the blood sugars, then definitely the glipizide is a good choice, and preferably so cheap also. The molecule cost is about 70 rupees or 1 rupee. So your Glyinage, MF, etc. Even if you use the 1 BD or the TID, maybe 3 rupees or 4 rupees per day. So it's mostly the rural Indian drug and a very cheap drug. At the same time, it is a sulfonylurea, but you have to give it in a BD dose or the TID, so preferably the TID.
Which of the following anti-diabetic agent is not associated with weight gain?
Right answer. Insulin increases the weight. You have seen the pictures, 21. The first fellow got the insulin is the Thompson. Okay, the weight is just 9 kgs or 10 kgs. After insulin therapy, very chubby. You see the dog, Marzano. The dog's name is the Marzano. So that is also very thin and lean. And after giving the insulin, it has become very smart. So you all know that after the insulin therapy, all the people will gain the weight because it is an anabolic hormone. So it increases your glucose synthesis. It increases your liposynthesis. It also increases your protein synthesis. So what happens in insulin deficiency? There will be proteolysis, there will be lipolysis, and there will be glycogenolysis. So all these hangama is because of the insulin. It's a very beautiful molecule, anabolic hormone, increases your weight. Glimepiride, sulfonylureas. So the two important side effects of the sulfonylureas is, one is hypoglycemia, the second one is weight gain. So for that reason, now the sulfonylureas are at the back seat. So as someone saying that the first drug to be used is the metformin. After metformin, what? Then after metformin could be SGLT inhibitors, or it could be the gliptins, or it could be the acarbose, or it could be GLP-1 receptor agonist, but not the sulfonylurea. So now the sulfonylurea at the last stage. Okay, so if you want to practice the evidence-based practice, but when you are in the rural setup or in the general hospital setup, when the other drugs are not available, then you can use these glimepirides. Pioglitazone, a beautiful molecule. So his brother was banned. What is his brother's name? Pioglitazone brother's name, rosiglitazone. And rosiglitazone was banned, and it has given a great impact all over the world as far as the pharma industry is concerned. So what is the lesson we learned from the rosiglitazone? It causes a lot of myocardial infarction. Now, if anyone, any pharma fellow wants to introduce a new molecule, all these new molecules should be go through the cardiac study. So when the cardiac study, they are normal, when there is no deleterious effects on the heart, your MACE or your heart failure admissions, etc., less with this drug, then only this drug will be available for the public. So all the diabetic drugs has to be screened for as far as the cardiac function is good or not, is cardiac protective or cardiac negative effects. So pioglitazone is a good molecule. What are the side effects of the pioglitazone other than your weight gain? Yes, urinary bladder carcinoma in males especially. Yes, osteoporosis especially post-menopausal women. Good. Hepatotoxic. Yes. Heart failure. Okay, it should not be used in the obese individual. And also it increases the fluid overload. And also delusional anemia. So some people will be on the triglyceride at 4, pioglitazone. So after 6 months or the 7 months, if you see the hemoglobin, it will be 6.5 or 7. And after pioglitazone therapy, the weight earlier 80 kg is now 90 kg. These two are very common in our clinical practice. So reduction in our hemoglobin or increase of the body weight because of the pioglitazone. Now the acarb has nothing to do with anything, these things, weight gain.
Which of the following insulins has the longest duration of action?
Excellent, right. NPH acts for about 12 to 14 hours or 16 hours. Okay, so that is the reason it has to be given twice a day also. Okay, deglutide is the longest acting. What is the maximum duration of the deglutide? Yeah, 36 to 40 hours. So even on alternate is also you can use the deglutide out of the box. Okay, so actually beyond 36 hours deglutide action. And another advantage of the deglutide is flexibility in dosing. So today you can do the deglutide at 8 p.m. and tomorrow maybe 10 p.m. and day after tomorrow maybe at the 12 night, and next day maybe at the 2 p.m. So the flexibility of the dose will be there. Flexible in timing is very much there with the deglutide because it acts beyond 24 hours. Glargine, what is the duration of the glargine? We say 24 hours, but RT 18 to 22 hours. Okay? So that is the reason now the deglutide is getting more and more prescriptions when compared to the glargine. Now the glargine is the number 1 molecule in the world. So the famous brand name is the Lantus. Now we have the Lantus, Basaclar, etc. etc. Okay. Last one is right, not the Getimer. That is the Getimer. What is the co-formulations? Recent advances, finally exam going. Insulin co-formulations. Deglutide plus aspart. Deglutide plus aspart. Okay, so that is our now that is your co-formulation. So by using this deglutide plus aspart, so you can control the postprandial blood sugar and also the basal hyperglycemia. So with the 1 shot or the 2 shots, you can control the 24 hours blood. So some of the people know they take breakfast maybe the 2 or 3 eggs or some fruits, and the night time also they take maybe 1 or 2 chapati or the pulka and then the fruits. So major meal is the lunch. So in those people, if you use this co-formulation, deglutide plus aspart, 1 shot before the lunch, so that takes care of the postprandial lunch with the aspart molecule, and the remaining 24 hours with your deglutide. So that is the advantage of the insulin co-formulation.
Which of the following drugs is the best choice for combining with insulin?
Excellent answer. This metformin can be combined with any sulfonylurea. Metformin can be combined with your acarbose. Metformin can be combined with your pioglitazone. Metformin can be combined with your gliptins, maybe sitagliptin, saxagliptin, veldagliptin, lenagliptin, teneligliptin. And metformin can be combined with your gliflozones, canagliflozin, dapagliflozin, and empagliflozin. So the metformin can be combined with any other molecule and also with the insulin. So that is the beauty of the metformin. Right answer. You have checked for it? Oh,